the okay. If the shape changes over time. But for the time being, this is what we have to focus on. So when you go to see a patient on a ventilator, majority of people focus on the hemodynamics on the bedside monitor, and they focus on the numbers on the whatever is written there as the numbers. But what would be great if you would look at these graphs and see if they make any sense for you. To remind you, this is the correct waveform that you should get on pressure when you are doing volume cycled ventilation. Uh, when you are using the decelerating mode, as somebody goes from inspiration to expiration, the flow becomes in the opposite direction. People tend to take a longer time to exhale before their next breath, and during that period of time, a certain volume is delivered. The On the pressure waveform, you will be able to see the peep, and if somebody's trying to take a breath by themselves or an assisted breath, there will be a negative deflection at the trigger area in this setting. So what can you use these to diagnose? You can use the pressure waveform to look for air trapping. You can look for airway obstruction, whether you have a bronchodilator response or not. Obviously, when you maneuver, when you put an inspiratory hold, you'll be able to determine the plateau pressure. And if somebody's exhaling, you will be able to see a little bit of a change in the square waveform that I showed you. Clearly, asynchrony would be something that you will see, and whether the patient has a triggering effort or not. The most commonly looked at part of the scalar is the flow waveform, because you can decide on air trapping much faster, clearly for airway obstruction and whether somebody is exhaling. So all of these will add to each other. And remember that because you're looking at a like a volume control setting, the pressure waveform becomes a dependent variable. So if any of this happens and the flow pattern changes, the pressure is going to change. So the combination of these two will give you a certain diagnosis. We rarely look at the waveform at the waveform of the volume, but often you can tell how big of a volume they're going to get. And in those patients who you believe they're getting too much volume, particularly if you're targeting a low tidal volume strategy like an ARDS, you want to make sure that every breath is the same, because sometimes you will look into breath stacking in it. And I don't mean severe breath stacking, but I mean like the milder forms of it that you may be able to tell. Um, so this is something that you have to kind of really look into every time. One thing that I didn't mention on the previous slide is oh, if you are if you have decided to use a square wave for a flow of gas, the pressure is not square anymore. The pressure becomes like this. So the patient here doesn't have any effort. I deliver a 70 liters per minute of a gas. Pressure inside the airway ramps up. I put an inspiratory hold. I will get the plateau pressure, because during the hold, there's no more air movement. So the alveolar pressure and the pressure at the airway become almost, not almost, they are equal, unless there is some severe airway obstruction that they are not communicating with each other. This breath is what's triggered, and can tell that the patient is triggering. Also remember that if the patient is triggering the breath and you only decide to look at numbers on the ventilator, you will have falsely reassured that the peak airway pressure and the plateau pressures are low. And the reason for this reassurance is because the ventilator adds them. So it adds a negative pressure to the total pressure, and you may end up a falsely reduced number. How can you check on a bronchodilator effect, for example? So this is somebody who got a square waveform, and they have very prolonged expiration, and then after you give them a bronchodilator, this is not the immediate breath, but a few breaths later, you can tell that their expiratory time is decreasing. Um, Auto peep is another thing, like air trapping, and intrinsic peep can be determined by just simply looking at the way, like you would have a hint that this is happening uh, when you look at the exhalation port, at the exhalation flow, and you realize that the breath never ends, and the next breath comes in. If you add this to the um, tidal to the volume that you're getting, to the actual tidal volume that you're getting, you will see that on breath by breath basis, the tidal volume increases. And often this gets missed, and they are calling you to take care of somebody's blood pressure because the patient's heart rate goes up, or they went into atrial fibrillation and their blood pressure is dropping. So instead of focusing on like somebody starts to take care of the heart and the blood pressure, and instead of adding up the bad effect of the ventilator that is causing the problem. So when you're looking at dyssynchrony, you have to look at every aspect of the curve and figure out where the problem is happening. And the problem can be happening at the trigger part, at the initiation of the breath, or at the delivery of the breath during inspiration, or at the end of it during expiration, or better to say, during the cycling of it. And each one of them has their components, and you can divide the asynchrony into three categories basically. There's the triggering category, there's the flow category, and the cycling category. Here we show a patient who's getting a breath, but then he tries to trigger, and there is a little bit of a blimp here, but the pressure never. I'm sorry, the flow is so little that it cannot really be sensed by the ventilator based on what the sensitivity that we have set it at. So you will have these efforts of inspiration and then expiration, but the machine couldn't care less about what the patient is doing. And in those settings, you see these little blimps in the flow rates and these blimps in the pressure curve, but they're not translated into an assisted breath. In those situations, this is a trigger-related asynchrony, and your solution has to come with adjusting the sensitivity of the ventilator. Sensitivity of the older ventilators used to have only pressure related, meaning the patient has to generate a certain negative pressure by which they will be able to um, trigger the ventilator to assist them. The newer ventilator have made it easier, so the inspiratory valve opens when a certain flow is achieved. So if somebody initiates the breath and they create like 2 liters per minute, then the ventilator senses it and it gives a breath. So when you have something like this, you have to look into how the ventilator is set, and changing the sensitivity may be good enough. Uh, uh, so the ineffective trigger is going to always cause a lot of work on the patient's behalf, and when that happens, fatigue occurs, and you may end up with breathlessness that you will find uh, it associated with agitation, and this agitation would lead to more sedation, and you get into a cycle that is impossible to do. Now, in special situations, particularly in like patients with COPD or asthma, when they are actively ill, and they have an element of auto-PEEP, um, no matter how you adjust the sensitivity of the ventilator, the patient has to generate a much bigger uh, pressure in order to overcome for them to be able to generate a breath. So let's say like their autopeep is 5, and the you set the sensitivity on the ventilator at 2. They have to really achieve a -3 for them to be able to get the breath in. But when you put the sensitivity at 2, they would never be able to achieve it. So all their effort becomes useless. Um, and this is where whenever the auto peep is very high, like if somebody's auto peep is like 10 or something like that, you have to add peep to them so that what they need to generate will be much smaller, because you don't have to have this big gap between the intrinsic peep and the applied peep, and it will be much easier for them to take a breath. And that's something that you have to take into consideration during um, ventilating somebody with a severe airway disease. Now, the opposite is over triggering. And this, when you see something like this, you tell yourself, oh my God, this patient wants like 50, 100 breaths. And then you realize that they are uh, auto triggering, not necessarily because this is their needs, but because you set the ventilator to sense any little movement. For example, when somebody has a hyperdynamic precordium, and every time the heart beats, it kind of mechanically will affect the pressure, uh, uh, um, and secondarily the ventilator misunderstands and thinks of it as a trigger for a breath, and it will deliver the breath. When you have like a big amount of secretions or water that has accumulated in the inspiratory limb of the ventilator, the water starts to oscillate in that tube. And as it oscillates in the tube, the ventilator thinks that the patient is taking a breath, and they want to give them a breath. Those are little things that you have to pay attention to when you are called in to see a patient with when they are very, very fast. Because I mean, and actually, when the rate of the ventilator is equal to the heart rate, even in a bradycardic individual, it's abnormal. Anyway, that was a joke. I wish I can hear you laugh. Anyway, okay. Uh, so what happens when you have an inspiratory problem? What happens when your flow is a problem? So whenever the flow can be either too much or too little, and the way to tell is like when you're delivering the breath, uh, like you're giving it in a decelerating mode, and you get a waveform on the pressure like this, like it's scooped. It's what you refer to as scooped, where the pressure starts to increase, then it deflects down, and then it goes back up again, just because the patients had an added effort in order to get them. When you have something like this, then the patient is working very hard to breathe, and you have to kind of readjust the flow for them to take it faster. And this is something that you commonly see in somebody with COPD if you set the flow very low. Remember, people who are obstructed, they are dependent on having a fast air flow, and as you have the fast flow, they have enough time for themselves to exhale, and the faster the flow of gas, the shorter the inspiratory time, the longer time they have to exhale. And that's what they are used to. So if you don't pay attention to that, and you give them like a regular flow rate for anybody, like 40 liters per minute or something like that, you will end up with, um, um, I mean, somewhat of an air hunger, and you will see them working hard and scooping this uh, uh, waveform. The opposite is true if you have very big of a flow. Like you will end up with instead of a pressure waveform that's square, it will look like as if it's ramping down. And this is a lesser of a problem, but it actually leads to fatigue because the patient doesn't know what to do with it. And sometimes they start to breathe faster just because they are uncomfortable. So you really want it as pretty of a square as you want when you are using the decelerating mode. Let me hold off now and see if you guys have any questions. I guess everybody's passing. No questions? Good, we continue. Um, cycle asynchrony. Cycle asynchrony occurs, uh, and this is actually perhaps the most, in my mind, a kind of a more dangerous way of having somebody breathe. And if you ignore all the writing, look at this graph over here. And this is like you are often called in to see uh, a patient with this is pressure, this is flow. On the pressure, you see two breaths, and on the flow, you see two inspirations and then an expiration. Now, unfortunately, this is called double triggering, which is very annoying because it has nothing to do with triggering. It has something to do with the fact that the inspiratory time is insufficient for the patient, meaning that the patient inspiration, his brain and his physiology wants him to take a longer breath, like he wants the inspiration to be longer. So as the patient is inhaling, the ventilator is turning off on him and wants him to exhale, but he's not ready to do that. So he continues to inhale, and as he does that, it stupidly thinks it's triggering again, so it gives him the second breath. So what you end up with is a picture like this. And if you were to look at what happened on the amount of volume that reached this patient's chest with the first inspiratory effort, it records 0 because he hasn't really done anything. And with the second breath, it records double. So in reality, while you think you have put somebody on a low tidal volume to be ventilated with to protect their lungs, every breath he's getting double, which is very similar to the control group if you were in a study. And those tend to be dangerous. And that is one hint that somebody is going to go into autopep that you have to pay attention to. Questions on this one? So, what's the solution to this one? The solution is actually increasing the inspiratory time and or increasing the volume. And when it comes to increasing the volume and you know that you're in trouble with increasing the volume if somebody has ARDS, you opt not to do it and go for increasing sedation. But you have to make sure first that they have inspiratory time and you try to control them that way. The annoying thing, this is also a very similar graph to something called reverse trigger. Before I go to reverse trigger, um, when you look at the patient here, anybody, what do you think they are doing when you look at them? Like, are they inhaling, exhaling, using muscles, not using muscles, assuming all of them are not paralyzed? Anybody?
Inhaling and using muscles.
Excellent. So they are really active. This activity will tell you that most likely this is double triggering, and just work on inspiratory time or adjusting flow. And like in the newer ventilators, it's the time that we adjust. In the different ventilators, you can actually adjust the flow itself. And remember, like flow and inspiratory time are quite related. Uh, mathematically related, because flow is nothing but volume over time. So So you either adjust the volume or you adjust the inspiratory time to get them to have a longer inspiration. In reverse trigger, though you have something like this, but you will see nothing active on the patient. And this is reverse triggering is related to some neurorespiratory coupling. It's musculoneural coupling that all of us have, and was studied predominantly in people with exercise, but when on the ventilator it has been associated, it's related to a vagal tone, a vagal reflex that occurs. So when people have severe, like they are really, really heavily sedated, not paralyzed, heavily sedated, they tend to do this. And the difference between it and double triggering is often you see it cyclic, like it's not like as random as with double triggering. You see something like this in double triggering, and at the bedside you see a patient that's not moving at all, not having any effort. And when that happens, the solution is trying to readjust sedation, and some sedatives are more prone for this than others, but it is patient dependent. So you have to kind of play around with sedation, and sometimes you have to liberate them from sedation, and tolerate a period of time of something like this that's kind of a bit on the dangerous side before you optimize their ventilator strategy. Uh, Now, this is the severe form of it. This is anybody will look at it and say, "Oh, this is happening. We have to do something about the inspiratory time." But sometimes you see it in a moderate way, and like in the graph in your on the bottom part of the screen, you see the mouse. Do you guys see the mouse?
Yes.
Yes.
So in this one here, you see the pressure and the flow. You see the you would think it is an attempt to take a breath, but in reality, when you look at it, it's kind of the exhalation is going in the same direction, and that's nothing but this in the making, but in a milder form. When this happens, the amount of support that the ventilator is giving becomes less. And you can see, like, if you look at the support that this ventilator is giving the patient is not as good of a square wave as it's supposed to be. Instead of it being like this, it has been hindered to kind of perhaps nothing. And the patient's work of breathing is much harder, and the support from the ventilator is less, and these people go into fatigue and they will end up with inability to come off the ventilator later on. And more importantly, they may end up in kind of further injuring the lung, and when you're trying to support their ARDS, it might get worse. Now, I have to admit, if I see something like this, I will miss it. But the only thing to me it would be odd is, my God, this expiratory phase is so small. Like in principle, the area under the curve during inspiration and during expiration should be equal. But in here, it is not. And the breath is ending without any excess flow inside. So I cannot blame this on autopeep. But it's kind of, I guess I should start thinking about it more as dysynchrony to do something about it. These are harder to identify. These are the ones that we identify very commonly. Uh, this is kind of a summary slide. It's nothing really important. Oh, this is what I mean by the I don't even remember my slides. So this is what I mean. Like, if this is what it's supposed to be, the ventilator support. This is how the flow is supposed to be, but it is not. So you see the end of the expiration in the right direction, but there's something in here that is being recognized by the ventilator. So all this work here that is being done is done by the patient. Is that clear?
Yes.
Okay, good. Uh, all right. So this is the cycle. Now, let's say somebody is being, and so this is the premature cycle. This is when they need an inspiratory time a little bit longer, at least in part of it. There is also the opposite. Like they have too much time to exhale, and that's what you see over here. Like, you have a big part. This graph is not the best, but you see the exhalation part has occurred, and then you have a flat line for a while before the next breath is happening. So when that happens, the patient tends to kind of not like it, and you'll end up with a little bit of a beaking because they keep on exhaling it out, and you end up with a beaking at the end of the pressure waveform. So what you need to do in those settings is to give them less time to inhale. After all, inspiratory time, when it is optimal, it facilitates adequate oxygenation. You don't want it too short and you don't want it too long. You just want it just right. And in order to optimize it, you have to kind of look at what's happening with the pressure curve. This is redundant. Um, okay, so this is the inspiratory dysynchrony that we talked about. This is a summary slide basically, and this is when your cycle is a problem. Inspiratory dysynchrony, you see the scooping up in the pressure, and in the cycle dysynchrony, you see the double triggering and absence of expiratory flow in the beginning of it. Very good. Um, so I talked about this earlier, but this is the graph that shows, like, always remember, like if I have a square waveform, my pressure curve is going to be like a triangle. If I have a decelerating flow, I'm going to have a square waveform. I don't know why I put this in. Uh, for those of you interested in mathematics, not mathematics, it's a little bit of physics and equations. When you're dealing with adjusting the I time, inspiratory time is calculated for volume control under a flow square wave as the tidal volume divided by the flow, and that will be the I time. So if you are sure that you are dealing with a square waveform, you can determine the inspiratory time easily, or the flow easily, depending on what the ventilator allows you to do. If you are dealing with volume control with decelerating flow, it becomes a triangular thing. So you have to take the 2 points from the top to the bottom, and kind of it will be the sum of them. Um, Tidal volume divided by that sum multiplied by 2 will be your inspiratory time. In pressure control settings, you directly set the inspiratory time. And in pressure support, you have to set up something. So, and actually, majority of times there's a default that the ventilator does. Remember, pressure support, patient is taking every single breath. They initiate it, and as they initiate it, they generate a flow of gas. And they usually, like if you remember how you take a breath, the first part of it is you achieve your peak flow in the initial phases of the breath. So the maximum flow is achieved. So you tell the ventilator to turn off the breath once you reach a certain level of flow, either 25% or 50%, and that's how the breath gets terminated. Um, uh, and during that period of time, the as you set it and how the calculation becomes a little bit harder to decide what the inspiratory time is going to be. As for PRVC, the pressure regulated volume control, or the autoflow that we have, we just simply directly set the time. Um, Rise time, I don't really spend too much time with it because it's kind of the impact that it has on the breath is much less than the others. But remember, if you're giving the rise time, if you have the slope by which uh, the breath is being given is very fast, you will achieve your tidal volume faster. If it's the slope is slower, it tends to achieve it a little bit slower. There is some work on it, but actually beyond my level of expertise. That there are certain um, parameters that people thought studied it, and they thought that the work of breathing will decrease if you are delivering the breath at a slower rate. But again, I have to study a bit about it a little bit more. I tend not to kind of play with it much. Um, anyway, we talked about this. Auto peep is very important, you guys, and we have to kind of pick upon it at the bedside as soon as possible. One way of to pick at it is by looking at the flow and realizing that uh, the next breath is happening uh, before the flow has ended. And the other one, which is actually very very important, is that your area and for inspiration should be equal to the area on your expiration. And the area is what's the area? It's flow times time, which gives you what? Flow times time is what?
A volume.
Good job. So the volume during inspiration should be equal to the volume during expiration. If it's not, it's either staying in the patient or he's leaking it somewhere, right? So this will be a hint. So if he's leaking it somewhere, you see that the volume down, like on the third graph, is going to be lower. If you see that the volume down is getting higher and higher with every breath, you know they are trapping. And the last thing to recognize auto peep with is like when you are seeing double triggering. What are the complications? Are these helpful? Okay. Um, Problems that are associated with positive pressure ventilation are several, as you all know. The circulation is a problem, the lung is a problem, and even gas exchange sometimes gets a hit if it was not done properly. Um, these like we're running out of time. These I will put them in a format and share it with you soon, along with a couple of reading articles. It's 5 before 8. Let's stop here and kind of entertain some questions.
I had a quick question. Can you hear me okay?
Absolutely.
Okay. So sometimes the patients are breathing on their own when they trigger their breath. They'll breathe at closer to like 10 mLs per kilo or 12 mLs per kilo, despite the ventilator being set at a 6 ml per kilo. I've seen sometimes when we're closer to extubation that we increase the tidal volume in order to match closer to where they are. My understanding is to decrease their work of breathing. And I guess my question is like, is that okay if you're closer to extubation versus closer to paralysis for more lung protection?
Okay.
Or
So
not paralysis, sorry, sedation.
This is very important. This is very important. So the 6 cc's per kilogram, I don't know if you guys have seen Martin Tobin's editorial in the Annals, is gonna be taken off the pedestal. And the reason for that is like you have to have, similar to chemotherapy, similar to everything, you have to have like targeted goal for each patient. So earlier on in the course of somebody's illness, they try to take big deep breath because they are in very bad shape. And the larger volumes that they have are associated with large transthoracic pressure swings, which will worsen the lung injury that they have. Uh, Either if they were spontaneously breathing or even on the ventilator. And on the ventilator, it's even worse because it's kind of these pressure swings, you cannot even measure them. So for those settings, in the earlier courses of their illness, sedation and paralysis becomes crucial. Once you sedate and paralyze them and take their effort off, you will have the capacity to measure or monitor their lung mechanics with compliance and resistance. And according to your findings, you will proceed. And we will proceed with not only a relatively low tidal volume, which needs to vary depending on what the plateau pressure is doing. So you really want the plateau pressure to be below 30 at all times. So, and you keep on decreasing the tidal volume for that. But also by optimizing PEEP, because as you optimize PEEP, you will, as you increase the PEEP, the difference between the plateau and PEEP gets smaller because you're recruiting lung. And when you do that, you will end up with a decrease in your driving pressure, which is the plateau minus the PEEP, until you reach a point where it doesn't happen anymore and it becomes a fixed number and you cannot do anything with it, meaning that you've reached your limit. You stay there. As they get better and their compliance improves, you allow a little bit of a better tidal volume. And this, as long as their pressures are still on the low side. And when they're trying to, when you liberate them from everything and you believe they are ready to be extubated, usually they become, their tidal volumes gets, if their tidal volumes increase significantly and you are below their limits, they're one of two things. Either they are feeling short of breath because the tube is in there and they are partially obstructed from it and they just are sighing constantly. So you want to take that out fast, and it's immaterial what you do with the ventilator. Or they are really not well yet. And in those settings, you have to reassess their mechanics. And if their mechanics are poor, then you sedate them again and you don't take them off the ventilator. Does that answer your question?
Yes, thank you.
Now, again, the low tidal volume strategy is the right thing. What's the value of the low tidal ventilator strategy? It depends on the physiology of the patient. You guys know where the 6 cc's per kilogram came from? So there was some older literature, like in the, I want to say in the 50s or 60s or something like that, where somebody, I think he was a veterinarian, who measured the tidal volume on a bunch of mammals, like rats, cats, whatever, and including humans, and they averaged out 6.3 cc's per kilo. So that's probably where it came from. So you and I sitting here, well, this is how at rest, this is what we do. Next. Aziz. Jojo.
Yeah.
Anything?
Yeah, I had a quick question. When we select the patient trigger on the ACBC mode, it's either the pressure or the flow, the trigger sensitivity that you select. Is there any time that you select one over the other, or is it randomly selected?
Well, actually, in the past, we only had pressure. Currently, the trend or the default is flow because it's easier.
Okay.
And the majority of the newer ventilators, actually practically all the ones that I've read about, deal with flow because it's easier, because that's how they gauging the inspiratory limb for it. Plus, you really don't want to make it harder for anybody to breathe. So with pressure, like we used to have pressure, but we always set it as at -2 really, so that it would be the least. With flow, you can even get it lower than that. So majority, the default is flow now.
All right. Okay. All right. Thank you.
Oh, sure. Helpful, not helpful, off your head, not off your head. Feedback to me.
I think Aziz has a question in the chat, but his microphone's not working.
Okay. My microphone is not working. What's your question, Aziz? Write it. Oh, he texted. Doc Hejal. My microphone is not working. I need to review it again and will reach out to you. Okay, great.
Sorry,
Yeah,
I thought
sure.
it was a question.
No problem. All right, guys.
Thanks, Dr. Hejal.
You take care.
Thank you, ma'am.
Thank you.
Sure.